So antepartum hemorrhage, it is a bleeding from the genital tract after 28 weeks of gestation up to delivery. So that is of two things comes under that: abruptio placenta and placenta previa. Abruptio placenta is the most common cause of antepartum hemorrhage. In low-lying placenta, the edge of the placenta lies within 2 cm from the internal os but does not cover the internal os. Placenta previa is a condition where the placenta is implanted in the lower uterine segment. True placenta previa, where the placenta covers the internal os partially or completely. The major 3 placenta previa include posterior marginal, partial central and complete central. So there are type 1, 2, 3, 4 placenta previa, where the lateral placenta previa is where the placenta dips into the lower segment but does not reach up to the os. That is lateral. Marginal placenta previa is the placental edge reach up to the os. Placental reach up to the os. Incomplete or partial central. Placenta partially covers the internal os. Partially covers the internal os. Complete or central, in which the placenta completely covers the internal os. Completely covers the internal os. Next is preeclampsia is a risk factor for abruptio placenta. Preeclampsia is a risk factor. Preeclampsia is a risk factor for abruptio placentae, not placenta previa. So risk factors for placenta previa are age above 35, multiparity, cigarette smoking, cesarean section, past history of placenta previa, assisted reproductive technology, multifetal pregnancy, succinate lobe. Painless recurrent vaginal bleeding is seen in placenta previa. So placenta previa is a in that there is a recurrent vaginal bleeding is seen in placenta previa. Bleeding PV is there. Painless recurrent bright red bleeding is there. Uterus is relaxed. Size is directly proportional to period of gestation. Floating of head of the uterus is there. Fetal heart sound are present. Stalworthy sign is seen in low-lying placenta, especially the posterior type, slowing of the fetal heart rate on pressing the head down into the pelvis, which recovers promptly as the pressure is relieved. It is called Stalworthy sign. Investigation of choice is transvaginal ultrasound. Next is amniotic fluid embolism. Amniotic fluid embolism, the main features are hypotension, hypoxia, disseminated intravascular coagulation. Antenatal diagnosis of vasa previa can be done by color Doppler. So what is vasa previa? Vasa previa is a condition where the fetal vessels travel within the membrane and overlay the cervical os. Hence, there can be bleeding during cervical dilatation and membrane rupture. Investigation of choice is color Doppler, Singer alkali denaturation test, AMP test. So biophysical profile, multi-parametric screening test, assess uteroplacental insufficiency. So the biophysical profile consists of 5 components: breathing movement of the fetus, amniotic fluid volume, tone of the fetus, movement of the fetus, non-stress test. Biophysical profile is directly related to fetal pH and fetal outcome. A score of less than 10 is associated with a pH of 7.2. Score 0 is associated with 100% fetal acidemia. Modified biophysical score has only two components: non-stress test and amniotic fluid index. Seminal vesicles and vas difference could be bilateral absent congenitally in cystic fibrosis. In Hutchings triad, there is Hutchinson's teeth, interstitial keratosis, and sensorineural deafness. Hutchinson's teeth, interstitial keratitis, and sensorineural deafness. In postpartum hemorrhage, if it is vaginal, it should be more than 500 ml. If it is cesarean section, it should be more than 1000 ml. Primary postpartum hemorrhage is within 24 hours of childbirth. Secondary postpartum hemorrhage is after 24 hours up to 12 weeks of postpartum.